in a journey. I think I'm now sharing. Do you hear the voice?
No,
No.
not yet.
Oh. Is it? Sorry. Maybe.
Shall we get Pravin to give his talk first, and then in the meantime we can adjust this?
Yeah. Or I can unshare.
Sure.
Share computer sound. Sorry. Just a second. Imad, where is that share computer sound?
Okay, we can see it now, and you can play it.
Do you hear the voice?
Not yet. We can see the video, but we can't hear the voice yet.
Probably Apita is with us. He can share. He can share it.
Okay.
So then I'm unsharing. Stop sharing. Maybe the other speakers may make his talk, and then Apita will share.
So we continue with Dr. Salunke, and then we come back to Atul's talk, okay?
Definitely, yeah.
Yeah. So I've introduced Dr. Salunke, also from India, with a talk on surgery with decompression for Chiari malformations.
Yeah, thank you very much for the invitation. And I think I'll straight away share my slides. So is that visible now?
Yes.
Right. Yeah, so I'm going to talk about, it was actually, my talk was following Professor Goel's talk. And this was actually controversial as compared to his philosophy. So it would have been better if he would have spoken first, but nevertheless, this is going to convey the whole thing. Right, so I'm going to talk more about the decompression and why is it necessary for patients with Chiari malformation. I have a disclosure. Professor Goel has a strong influence on my work, and I've been following his work and have learned a lot from him. And, this has been my journey over the last 20 years, and I've been really lucky to have him very close. But I have a different take when it comes to Chiari malformation. He says Chiari malformation is secondary to the instability, and decompression is not the treatment, fixation is the treatment, irrespective of whether you see apparent dislocation or not. So that is where I would like to differ, and I would like to share my own experience on this subject. C1, C2 fixation, I feel, may be an overkill in all cases. And decompression is the key. If you have listened to all the previous speakers, finally it all comes to decompression, irrespective of what is the cause of Chiari, primary or secondary. When we look at Chiari malformations, these may be present in utero as well. I mean, you can diagnose them in utero. whereas you never get to see atlantoaxial dislocation in utero. Of course, you may have patients with deformed joints, children with deformed joints, born with deformed joints, but they're never born with dislocated joints. They're born with Chiari malformations, but not with dislocated joints. So Chiari malformation cannot be a result of instability. That's the first point I would like to make. It cannot be a result of instability. It's like saying if you have listhesis, dysplastic listhesis associated with spinal dysraphism, meningocele, and the treatment of that would be actually fixing the lumbosacral spine rather than taking care of the meningocele. It doesn't sound really rational. So Chiari is unlikely to be a result of instability, and majority of the patients with apparent atlantoaxial dislocation do not have Chiari malformation. So this is something which is very typical, because Chiari cannot be a protective mechanism. It cannot be secondary to atlantoaxial dislocation, because majority of them do not have Chiari malformation. Almost 70% of them do not have Chiari malformation in those patients who have apparent atlantoaxial dislocation or the so-called basilar invagination. And the other way around is also true. Majority of the patients with Chiari malformations do not have apparent atlantoaxial instability. So is the nature unfair for those without the protective phenomena? That is something which we need to ponder upon. Decompression, as the previous speakers have all spoken about, foramen magnum decompression, posterior fossa decompression, and increasing the volume. 70% of them have good outcome. This has been my experience, and I'm sure the previous speakers would also have a similar kind of experience. 70% of them have a reasonably good outcome. And this is for Chiari without the so-called atlantoaxial dislocation or apparent atlantoaxial dislocation. Even some patients with Chiari malformation may have some ventral compression, the so-called clival canal line, and there's some ventral compression in a couple of patients. And we had published this, so you can see that. And even posterior fossa, simple posterior fossa decompression in these patients works in majority of them. This is an example where we can see just pure posterior fossa decompression, and you can see the syrinx disappearing, the Chiari reversing. So all that happens, ascent of the tonsils. So FMD still works, as foramen magnum decompression still works in majority of the patients. When we talk about decompression, it's also ventral decompression. Again, one of the previous speakers had spoken about transoral odontoidectomy and reversal, ascent of the Chiari and ascent of
İlk
the
konuşmacıda
Yeah.
sorry.
Yeah, so odontoidectomy, and however, once you've done that, it would require fixation. So this is an example. You can see that, and after transoral decompression, you can see a reversal of the Chiari, ascent of the tonsils, and disappearance of the syrinx. So of course, this is what we do. We follow what Professor Goel had actually given us in India. And this is an example of, look at the C1, C2 is actually, there is a relationship alteration. So you can see that very clearly. There's an altered relation between C1 and C2. And the so-called basilar invagination is actually a telescoping of C2 within C1. It's the vertical invagination or dislocation of C2 within the C1. And of course, if you fix that, just the posterior fossa, there's tonsillar herniation, but apart from that, you can also see there is some ventral compression. You just fix the C1, C2 in the reduced position, and there is ventral decompression. So finally, it is decompression. Even that fixation is actually gaining posterior fossa volume ventrally in an indirect fashion. So this is what we had published previously. This is Chiari with atlantoaxial dislocation, or the so-called basilar invagination. You can see there is the dens which is invaginating within the posterior fossa, reducing its volume, creating a further loss of volume of the posterior fossa. And it is not only the volume of the dens, look at the tenting of the dura. So it's a three-dimensional thing, it's a tenting. So the actual volume of the dens which has invaginated and the actual tenting of the dura, which causes a loss of the volume, is far more than the actual volume of the dens. And the moment we de-telescope this kind of invagination, it is going to gain a considerable amount of volume in the posterior fossa. So that is the whole concept, and this was again published. So it is foramen magnum decompression without any bony removal. So that was the concept. It's a ventral decompression, indirect ventral decompression, nothing to do with instability. This when applied to patients where there is no apparent instability. Here's what you see. This is all, there is some platybasia, there is kinking, there is ventral kinking, there is clival canal angulation is changing. The moment you distract the C1, C2 and fix it, there is increase in the posterior fossa volume. There is detelescoping of the C2. And this is irrespective of the instability. You just fix them together, the angle changes, and there is a considerable increase in the ventral volume of the posterior fossa. And that is what brings about improvement in the patient. So this is what, again, we have published. These are a couple of examples where we followed what Professor Goel had given us, but on a different, with a different perspective or a different rationale. So that is the concept, that you just reduce, you fix the C1, C2 with some distraction, and it brings about increase in the posterior fossa volume ventrally, decompresses the canal ventrally, and that is what brings about a significant improvement in majority of the patients. So this is what we have seen. Look at those examples. Another example, significant syringomyelia, C1, C2 fixation, and believe me, none of them required any posterior fossa decompression at that time. So this is what is the concept. You can see the entire C1, C2 gets detelescoped after C1, C2 fixation. There is change in the clival canal angulation, and there is ventral decompression, which is brought about by this technique, reduction in the syringomyelia, ascent of the tonsils. And yet another example where you can see the same thing, there is a change in the clival canal angulation after the C1, C2 is fixed. And this is what brings about the change in the decrease in the syringomyelia and reduction of the herniation. So that the concept is of ventral foramen magnum decompression without bony removal. That is what I would like to highlight. It's all about decompression. And then we did a lot of these cases without any apparent, the so-called basilar invagination, no apparent atlantoaxial dislocation. And what we saw, that the improvement was seen only in 70%. It was not in all the patients, and it was almost as similar to those with posterior foramen magnum decompression. So finally, we realized that this is probably not the cause. And there are a lot of difficulties which are encountered while performing a C1, C2 facetal fusion, especially in patients with Chiari malformation. That's because there's a significant venous congestion, incurved occiput, making the exposure of the assimilated C1 facet quite difficult, anomalous vertebral artery, which is seen almost in 30% of the cases. And of course, we need to cut the C2 nerve root quite often to expose the facets properly. This is yet another example, which is a true basilar invagination. Now, what the type A and type B, which was previously mentioned by Professor Goel. So this is extremely difficult. Try to fix the C1 and C2 in these kind of cases from the posterior aspect, and it is going to be difficult. So we did that. It's not that we didn't do it, and you can see that there is some telescoping, but the final outcome wasn't all that great. So we have problems of fixation, loss of neck movement, which is, it's quite unacceptable to a lot of patients. And finally, there's improvement only in about 70% of the patient. 30% keep on complaining that there is no improvement, and some of them even worsen with time. So now I'm going to talk about the failure of C1, C2 fixation in these patients, and we can see that this is an example. There has been reduction, increase in actually the syringomyelia, and there's no change. This is another example. You can see that the syringomyelia has actually increased. Though, yet another example, we can look at that. This is post-fixation, and the syringomyelia has actually worsened with time, and there was no apparent atlantoaxial dislocation in the preoperative period in any of these patients. So Chiari cannot be a result of the instability. Fixation alone is not going to help. Decompression in whatever fashion, posterior, ventral, whatever, direct, indirect, it's going to help. So it's easier to begin with a posterior fossa decompression. If it fails, then probably we can go ahead with a C1, C2 fixation. And ventral decompression only in cases where there's kinking or signs of brain stem decompression. So this is what we published. The perception about the Chiari malformation is changing in the last 2 decades, but what has not changed is the reality. And it is questionable how effective is the C1, C2 fixation in patients without any apparent instability. Again, we had a couple of more publications out of this. And so instability, somebody spoke about facets. And if you look at those facets, I'll give you an example. Now, this looks quite dislocated, unstable. So right facet has moved, the C1 has moved in front of the C2, and the left one has moved posterior to the C2. But This was a patient who was lying with his head turned in the gantry. This was a normal patient. There was absolutely no instability. So just looking at one parasagittal cut and saying that this is unstable, looking at the facets where there is no instability and saying that this is unstable, and fixing C1, C2 is something which is, it is difficult to fathom and understand. So this is the normal anatomical variation or normal anatomical picture which is picked up in different positions or variation of the position of the head inside the gantry, and one needs to carefully look at it before just labeling the patient as unstable at the CV junction. Again, when you have hydrocephalus with Chiari, decompress the ventricles, Chiari reverses. We have already heard it from the previous speakers. So it's a ventricular decompression. When you have syndromic craniostenosis with Chiari, again, posterior wall decompression, recently published by Gaurish and Sinali, and you can see that there is ascent of the tonsils, reduction of the syringomyelia. So it's finally about decompression. So it's all about decompression in some way or the other. If you decompress the posterior, the fossa, increase the posterior fossa volume in one way or the other, we have a lot of improvement in the Chiari and the syringomyelia. So decompression is the key. We decompress whatever ventricles, if there's hydrocephalus, posterior fossa. If we don't see any ventral kinking, we can do a ventral decompression by C1, C2 distraction, fixation, or odontoidectomy, and posterior cranial wall distraction in cases of craniostenosis. This, having said that, it's very important that if there is apparent instability, there is no doubt that you have to fix the C1, C2. We have already published that in case of Chiari malformation associated with the instability needs to be treated, the posterior fossa volume increases, and there is no need for any further foramen magnum decompression. So this is what we follow. If you have a ventral compression or kinking, irrespective of the apparent instability, then we would like to distract the C1, C2 and fix it. Without that, we would go ahead with the foramen magnum decompression in patients with symptomatic symptomatic Chiari malformation or syringomyelia. Finally, irrespective of all the treatment modalities which have been, we have worked out that if you look at the quality of life of patients, patients with Chiari malformation do not really are not very happy after surgery, and it seems that we are barking up the wrong tree. Probably the pathophysiology of Chiari is less understood, but as of now, decompression in some form appears to be the key, and a better understanding in future would give rise to newer modalities and better modalities. Thank you for your patient listening. Thank you.
Thank you very much. I'm grateful for your comment on facet dislocations. Obviously, you have to see it on both sides to be sure that an anterior facet dislocation is indicating instability. Otherwise, you're quite right. It may simply be related to a slightly rotated head. So now we make a second try on Atul.